Good morning, everyone. Welcome to day 2 of the Health Literacy in Action Conference. We're really excited to have a very timely plenary session here for you today, and we'll get started in just a minute. Please get comfortable. If you're on the East Coast like I am, get that second cup of coffee and get comfortable because we have a really great program for you today. First, we have a couple of housekeeping details. So if we could have the next slide. Great. So you will all be muted during the presentation. We will have time, I hope, for the Q&A at the end. So if you want to talk amongst yourselves, please use the chat function. But if you have questions for our speaker, please use the Q&A, and I will be monitoring that as the moderator for the session. Next slide. Please note that if you have any technical difficulties, either in this session or during the rest of the day, use that email box, info@HLA action or HLactionconf.com, right? Then that will get you some technical assistance. The presentations from the conference will be recorded and posted within 2 weeks after the conference, and you will access that through the IHA Solution Center. And if you are looking for continuing education credits, you must submit an overall conference evaluation to get your certificate. Everyone will get the link to the conference evaluation later today after the concluding session that Michael Valera and I will do. I also wanted to note, please do share information from this conference, whether it's through Twitter, whether it's through Facebook, whatever your preferred form of social media is. We have a hashtag for the conference, HLiA conference, and then also IHA and the Horowitz Center have their own handles on Twitter as well. So please do tag us if you are tweeting about the conference. Okay, so next slide. So great, it is my distinct pleasure to introduce a still UMD colleague, but with one foot in another world. And we're very excited today to have Dr. Monifa Vaughn Cook. She has a really stellar background in biomedical engineering and health information technology. And when we were thinking about the perfect person to talk to us about both the opportunities of technology, but also some cautionary notes that we need to take advantage or pay attention to, Dr. Vaughn Cook came to mind. So we're very excited to have her here today to talk about these opportunities and challenges. So Monifa, please take it away.
Thank you, Cynthia. Thanks for the introduction. So as Cynthia was mentioning, I'm going to be talking about the health literacy divide, some of the digitization opportunities and challenges, and how designing more patient-centered healthcare solutions can help to address that divide. A little bit of background on myself before I get started. So my background is in industrial engineering with an emphasis in human factors and ergonomics. I'm currently the director of Human Factors Education and Outreach at the MedStar National Center for Human Factors in Healthcare, where I lead academic education initiatives and also professional development initiatives. As Cynthia mentioned, I'm also on faculty at the University of Maryland, specifically in reliability engineering and mechanical engineering. And my particular expertise is in human-centered design, specifically looking at the characteristics of humans that influence how they engage with the system, the risks and errors that might be posed through that interaction, modeling those groups, and then also testing how different design changes influence and impact those groups. And that's really going to be the focus of what I'll talk about today. The National Center for Human Factors in Healthcare, where a lot of this work is also being propelled forward, we're an interdisciplinary group composed of different medical professionals, so doctors, nurses, for example, also engineers, human factors experts, informaticists, a wide range of professionals, which of course are necessary to tackle human factors healthcare problems. We do predominantly research with federal-based support, but also industry contracts for patient safety consults, usability consults, and then, as I mentioned previously, a variety of different educational initiatives. So before I jump into some of the future directions of what's going on with digitization in healthcare, let's talk a little bit about how healthcare has transformed over the past few decades. And as you know, as I'm sure many of you know, healthcare has been quite siloed into different specialties, different facilities, different professional divisions. And that has led to the siloing of information concerning the patient, which degraded care for many decades. And so the provider or the facility would hold patient information, which in turn meant that there was not a lot of interoperability or sharing of that information. So a lot of the efforts in digitization, of course, with the internet, and then incentivizing digitization of that information led to a lot of changes. So we had the Affordable Care Act, of course, that incentivized a lot of that digitization and interoperability. And so what we have now is more of an exchange of information. So there's still a bit of a struggle with interoperability, as many of you know who are either in healthcare or engaged with the healthcare system. But we see a lot of that information being synchronized to cloud-based systems or being held on the internet where it can be exchanged. We see a lot more options now for how patients can engage with the healthcare system. So instead of just in person, we have a variety of different mobile-based and telemedicine options where you can engage with your provider and various healthcare system functionality through whatever interface you might have. So this has been a great improvement, and this has actually led to a lot of opportunities for patients to integrate data and to be more engaged with their care, which we know can potentially lead to improvement of self-management outcomes. So what does that look like? Well, there's a few different ways that patients can now engage with the healthcare system from the perspective of digital systems. So of course, we have patient portals or personal health records where you can manage a variety of different information and also communicate with your provider. You can access lab tests, notes from your consults or diagnostics. You can also do scheduling. So that's all now digitized, although of course it's managed in non-digital means as well. And then, as I mentioned previously, there's several different modalities that interaction takes place. So remote-based modalities, which has really opened up options to address some of the disparities in rural or others who might have access issues to healthcare. Another really important update that we've seen over the past few decades is the integration of patient self-management devices and the digitization of that information. So I just talked about this information being synchronized or integrated with cloud-based systems. So there's now being a lot of opportunities presented where these systems are now being synchronized with other data, which is now enhancing the patient experience and enhancing their ability to engage more with their care. So this increases autonomy, and we know autonomy, when the patient experiences higher levels of autonomy and engagement, it's going to improve treatment outcomes. So this is all great. Lots of options for the patient to engage with the system, lots of different technological modalities and platforms. And this has the potential to enhance the healthcare experience and outcomes. However, we know that there's challenges with engaging with these options. And if those challenges aren't appropriately addressed, what will end up happening and what we've seen is that all of these various technological modalities and options are not being taken advantage of, or they're actually degrading the experience for some individuals. So the main question that has to be asked is, who is the patient? So many designers, vendors, or manufacturers of these digital technologies, an assumption is made that the patient population is a homogeneous group. So everyone engages with technology in the same way. Everyone understands health information in the same way, and everyone has the same skill set or competence when engaging with a technological platform. However, we know this is not the case. In fact, patients are one of the most heterogeneous user groups, and there's several reasons for that. And you're probably aware of these reasons as a patient or as a provider of patients for those of you who that's relevant. Patients are untrained. So there's no formal education to be a patient. Anyone can be a patient. There's no prerequisite knowledge that you are required to come into to engage with a system. So that's going to actually increase the variability. That's going to increase the heterogeneity. We also know that similar to the vetting process or the filtering that you might have when you join a profession or a job, there's no human resources department that's determining if you have the requisite skill set or the requisite training before you engage with a system. So this is really the wild, wild west, right? Anyone can be a patient, anyone with any skill set. So that's why I say that this is a highly heterogeneous population. So instead of the image on the left, in fact, what we see is more of the image on the right. So, so instead of one homogeneous group, lots of variability. And in fact, what we find is that individuals with similar characteristics, we have segments of the population who tend to engage with technology, tend to engage with the healthcare system in similar ways. And so the focus of what I'll be talking about today is how do we actually characterize? What are those segments? How do we use that information to help improve this engagement and the digitization? So one of the main factors that influences which segments you fall into and this heterogeneity is health literacy. So how patients understand and are able to engage with and apply health information to their particular treatments or health outcomes. And we know this varies widely. We also know that it's connected to other factors like socioeconomic status, race and ethnicity as examples. And so it's really important to understand what is the variability in health literacy among the population. There's a few different measures where this can be done. So one of the measures that's recommended by the Agency for Healthcare Research and Quality is the short test of functional health literacy in adults. And survey questions that look at word association and sentence comprehension. So there's a lot of options out there to actually quantify health literacy, which is going to help you decide what segments these patients fall into. But of course, these sorts of surveys, we don't find them in patient intake questions. So when you first sign up for a particular or first attend an appointment at a particular facility, this is not included in the preliminary questions. And there's not a lot of formats where this information is actually being solicited from patients. However, we do have other information that we know is highly correlated. For example, I mentioned the other measures like socioeconomic status, but we also have measures that are in the medical records. One of the measures that's been highly linked to health literacy is insurance, type of insurance you have. So we know from research and data collected that those who have Medicare and Medicaid and also no insurance are going to have lower levels of health literacy compared to those who have private who have privately insured health insurance. And so one of the big challenges is how do we actually capture some of this information to integrate into our decisions? So another measure that's really important and also quite linked to health literacy is digital literacy. So it's not commonly thought of when you're designing treatment strategies, but it's actually quite important when those treatment strategies involve digital technologies. So a comparison that I always like to think of is this idea of a flip phone versus smartphone. So there's not a lot of flip phones around anymore, but we commonly like to think of the old versus young paradigm when we think of technology. But of course, it's a lot more complicated than that. It's actually the issue of the extent to which someone's digital literacy impacts their engagement with the healthcare system. It's actually quite complex and can't be boiled down to how old someone is. So this is kind of an indirect measure of what we'd want to understand of their technological skills or competence. In fact, a more direct measure would be understanding how they actually engage with different functions, the extent to which they engage with these functions, and how frequently they engage with it. So here's an example of a question that we've used in my research to assess someone's technological competence or digital literacy. So how frequently do you browse the web on your mobile phone? Okay, so this gets directly at how much you're accessing more advanced functionality on your phone. Because in fact, you might find several older individuals who have smartphones, who actually own them, but only use them for incoming and outgoing calls. And so there's many different aspects of the problem that really have to be captured and quantified in order to understand what segments the patient might fall into. Another thing to consider in terms of digital literacy is how you're designing the system. Now there's characteristics of the patient that can influence their interaction, but there's also the design of the system and the extent to which the patient is able to interpret information that's being communicated to them. So you see here a set of icons. Some of you may recognize these, and we may take for granted the fact that everyone understands what these icons mean. For example, the home icon. If I want to go to a landing page, I press the home icon. Or if I want to access a menu, typically I see these 3 bars here, or I see three circles. Or if I want to navigate, if I want to go forwards, or if I want to go backwards, I see icons such as this. Again, oftentimes designers take for granted the fact that all patients know how to navigate and engage with systems and will recognize and understand the meaning of these icons, which is an assumption that is generally not held among this heterogeneous population for certain groups. Another issue that commonly arises is how do you communicate information to a patient through a digital system to say that some action is needed. So here's an example of self-management diagnostic device communicating that there's something wrong, there's an error. But what exactly is the error? And so these are common issues that we see occurring in design, where the interface is not accounting for the characteristics of the user, is not giving them appropriate information to allow them to effectively engage with the system. And when we see issues like this, what we start seeing is a divide in patients' experiences. So this is the health literacy divide, the digital divide, all of these characteristics that are influencing what the patient's experience is, and then subsequently what their treatment outcomes are. So we talked about health literacy and digital literacy. There's also a lot of other factors that are going to impact how patients interact with digital systems in healthcare. So some examples, we can have sensory factors. Okay, so we know patients are quite diverse in terms of how they perceive information. So there's a lot of eye diseases, for example, diabetic retinopathy, cataracts, glaucoma. We know a large percentage of patients do have those diseases. It's going to impact how you interact with screens. Most digital technologies have hardware and software integrated, so you have to communicate through screens. So imagine having an eyesight limitation or eye disease that actually impacts how you process that information. This has to be taken into account. Similar to auditory information. So if there's something that is alerting you that you need to take notice, but you have an auditory disease, or you just have reduced auditory acuity, this is going to then impact how you're able to engage with the system. Similar to touch, so diabetic neuropathy, arthritis, large swaths of the population have this issue. So imagine having to engage with some sort of a handheld self-management technology where you have to push buttons or grasp or do fine motor manipulation, but you're experiencing pain or desensitization in your hands. And again, this is a large percentage of the population who are going to have these issues, not a small minority. And these are things that are commonly not taken into account in digital technologies that are being integrated in healthcare. We also have analytical skills. So this is related to health literacy and digital literacy, but also how we process information, how we do decision making and problem solving. That's going to vary widely among the patient population. Mobility, we know, is also going to influence how we engage. So we talked about, for example, arthritis in the discussion of sensory. That's related to mobility, but there also may be broader functional mobility issues that may impact access to certain services, access to technologies, and also the ability to interact with technologies. And then we have interpersonal skills. So patients have to engage with other individuals within the healthcare system, healthcare providers, administrators, schedulers, et cetera. So the patient's interpersonal skills are going to impact that outcome. And these digital systems are of course meant to facilitate that interaction. And we of course know the individuals on the other side of that interaction, their interpersonal skills will also influence those outcomes. And then we have behavioral motivation. So I talked previously about the level of autonomy that the digital tool facilitates. We also know that the patient's self-efficacy and other factors that relate to how they feel confident with interacting with health information, that's going to impact outcomes. So if there's a lack of comfort level with interacting with the health information or the technology, that of course is going to influence outcomes. And then I mentioned previously the socioeconomics. And so that's a factor that we see quite relevant throughout access to both the technological tools, but access to the healthcare system. So these are just some examples, not an exhaustive list of some of the main ways, in addition to health literacy and digital literacy, that patients are highly heterogeneous. These are the things that are going to impact their interaction with digital systems in healthcare. So I mentioned these segments, right? So all of these characteristics, when you have a group of patients who have a similar grouping of characteristics, they form a segment of the population. And we know these segments exist. There's been lots of research that show there's certain segments with similar characteristics. And what ends up happening when we don't acknowledge these characteristics in the design of the digital systems, we find that certain segments there's a divide that occurs where certain segments do not receive the same level of care or not able to engage with the healthcare system in the same way. So we see treatment outcomes diminished for certain segments of the population, and they do tend to share similar characteristics. So we know all this, and this information, again, has to be integrated into how we design solutions. So I'm going to talk a little bit about, given all that knowledge, given that we know we have a highly heterogeneous population, there's certain factors that we know exist that define this heterogeneity. What do we do with that information? So how do we actually integrate this into designing patient-centered digital solutions? So the first piece is information. So we need to collect information on all of these factors that I just identified. Some of this information, as I mentioned, we can find it in medical records. Other information may have to be found through examinations or additional data collection. So there has to be an effort to collect this additional data so that we have a more robust data sets to actually define who the patient is. So that's really the first step. We need to enhance the data collection methods for patient intake and all of the data that's collected for the patient. With that, we can then start to classify what groups the patients fall into based on their responses or based on where they fall along particular data points. And one of the methods that I use quite commonly in my research to then group patients are data-driven patient personas. And what this means is that these are statistically meaningful groups of patients who are distinct from each other. So they're similar to the extent that they share characteristics, and these groups are distinct to the extent that they're statistically significantly different from each other. So this is one way that we can take all of this data, we can integrate it to actually understand what these groups are. Of course, it's quite resource prohibitive to design individual solutions for each individual patient. So what this grouping helps us to do is to consolidate that information so we can develop targeted solutions for different segments of the population. So I'm going to show you an example of what that looks like. On a prior FDA-funded study, we looked specifically at diabetes patient groups, and then later more broadly at all chronic disease patients. And of course, we know diabetes patients are some of the high-risk chronic, one of the most high-risk chronic disease patient groups just based on patient adherence and treatment outcomes. And so this is a good group to study in terms of how to develop digital solutions to help with their self-management and some of the activities in the outpatient setting, which a large percentage of diabetes patients' treatment is managed by the patient in the outpatient setting. So the question we were trying to answer here is, how do we design a digital tool more effectively for this group? Again, with the understanding that they're highly heterogeneous. So we did these patient clusters or these patient groups. And here's some examples of some of those clusters and some of the implications that came from that. So here's an example of one of the clusters here that comprised 20% of the population of the diabetes patients that we surveyed, looking at a variety of different metrics encompassing many of the factors that I mentioned previously. So these are mostly middle-aged patients with some college education. And we would consider this group to be low to moderate risk in terms of their engagement with the system. So they do have high health literacy, but moderate digital literacy. And they desire some really basic features in terms of engaging with the portal. But something that's really interesting about this group, the majority of individuals in this group actually had arthritis. So this is something, of course, that might be overlooked when considering the population and how you would design a software tool for them. But of course, how we engage with software requires a keyboard, a mouse, potentially a touch screen. So individuals who have more advanced arthritis may have difficulty engaging, and it may be prohibitive or demotivating. So considering different approaches like voiceover technologies, which are commonly utilized for various digital tools. That may be a solution for this particular group if engagement with a tool is limiting. So here's another example of a group a little bit older, less educated, and these would be the higher risk patients. So low health literacy, low digital literacy. But what's interesting about this group is that they actually desire more advanced features. So they want nutrition support, they want medication management integrated in their patient portal use. That's what they reported. So that poses a challenge because these patients may have more limitations when engaging with the healthcare system and with digital tools. So how do we now support them in this engagement? So that means that potentially these patients may have a different landing page or more guidance when engaging with the digital system. So not making assumptions that they understand basic navigation and functionality of the software tool, and also potentially providing training on how to engage with the patient portal instead of assuming that you immediately know how to navigate and find the information that you need. And one last example here, this is what we will call our low risk group. So these are individuals who are highly educated, they have high health literacy, high digital literacy, they want all the features. So they want all the bells and whistles of a patient portal. But what's interesting about this group is that the majority of them have eye disease. So we talked about this in the prior slide. So they want a high level of engagement, but of course, high level of engagement with a software tool means that you're looking at screens a lot. And this population has eye disease. So then how do you address that issue? Well, similar to the first group, we talked about the use of potentially voiceover. This group may also rely more on images rather than small text, and also enlarging that text as a way to better communicate with this group so that they can have the high engagement that they desire. So again, this is just a subset of the information that we found here. Now, once you have these groups clustered, as I showed in the example, what do you do with it? Well, there's a series of steps that are typically undertaken to actually execute this. So the patient modeling is done, as I just discussed. We now know what patient falls into each group. And then you do what's called use case scenario design. So each patient group may have a different use case scenario, how they're going to engage, what are the steps to address their needs when engaging with a digital tool, and then developing a prototype. And what's important here, which is commonly not done, is that you're engaging these patients earlier on. So you're engaging them when you have initial prototypes, not at the very end when you have a final tool developed. So you're engaging them to get their feedback, and then you're going back and designing and testing in the patient population. This is probably the most critical part and what would be considered essentially a participatory design approach, where you have patients engage in developing the various modules that are tailored to them. And of course, this is iterative. So this is not considered to be a static version of the tool. We're always taking input and feedback and making it better based on what we understand about the characteristics of this group. So this is a basic sequence of how we would actually address this, and one that that should be adopted by developers of the tool or those in healthcare who are implementing the tool. So now that we've talked a bit about the factors that impact patients, and then also how we then take that into account in the design process, what are some of these new innovative approaches that we're seeing that can actually take advantage of this information to better design or tailor solutions for patients? So I mentioned this idea of data. So we have to collect data that's in the form of patient surveys, intake, additional information that's collected in the observational screening, and through the consults. And this is all critical information to really understand who the patient is. So what do we do with that information after we know that this patient falls into this group? So there's a lot of different options here that could potentially be utilized. One is actually, and I hinted at this with the diabetes example, actually customizing or tailoring software features and design, okay? So again, when you go onto a website, similar to any system that you might engage with, you might be asked a series of questions, but of course these questions will be tailored at figuring out what silo or what particular subgroup that you actually fall into. And so, so this would actually, you know, in a best case scenario, this would tailor what you see when you then log on to the platform. So you would have a different landing page potentially based on how you answer those questions. And I talked about for the diabetes example, how you might then modify the information. You might have larger text. You might have a training session on navigation and engagement with the tool. You may even have different imaging that's presented to you depending on how you answer those questions and what information places you into those groups. The type and level of digital interactivity may also be modified. So what features you engage with, for those who want more engagement, this can actually enhance treatment outcomes. But for those who don't want more digital engagement, this can degrade treatment outcomes. So you can think of it like a digital spectrum where you fall on that spectrum is very much related to the level of digital interactivity that you desire. And so this is very much important and can be obtained, and then features and different services can be recommended to the patient, such as remote or outpatient telemedicine services that might help to enhance the patient experience. And then of course we have remote diagnostic integration. So we're seeing a lot now that these patient self-management devices like glucometers and blood pressure tools as examples. Some of these are collecting data and they're being transmitted directly to the healthcare facility or to the provider. So the idea is that if you're collecting continuous information about the patient and the patient's state, you can more proactively determine before something turns to a more serious health event or a disease progresses, where the patient is in terms of their health progression, and potentially intervene or proactively mitigate the risk of the disease progressing. And there's a lot of potential for that continuous monitoring of the patient over time, which would then lead to more tailored interventions in response to that information. Another future direction that we're already starting to see now is artificial intelligence automation of different functionalities in healthcare. So for example, chatbots, which we commonly saw in the consumer world in terms of when you're purchasing things online, we're starting to see those integrated in healthcare. For example, MedStar is piloting chatbots in 5 of its hospitals right now. And there's other attempts across the country also to do similar pilots. And the idea is that that you would engage with an automated system where you express a concern. So for example, imagine saying, I'd like to set up an appointment for the following, or even more broadly, I have a sore throat, okay? And then you would be asked a series of follow-up questions. Does that sore throat, is it accompanied by these other symptoms? And it would go through a set of diagnostic automation steps, which would hopefully lead you then to the correct services where then you can engage So first going through the diagnostic steps, and of course, the AI tool at this point doesn't have the capability to diagnose you, but could potentially lead you to scheduling-based services where you would be paired with a specialist or an urgent care or an individual who could better suit your needs, or even connecting you with a human operator to further triage the situation. And so, of course, in healthcare, we have a huge resource burden on the healthcare system. So this is one way that helps to relieve some of that burden and put it on software automation, while allowing those resources to then focus more on patient care down the line, and allowing the AI automation to take over some of the upfront tasks. So we're seeing a lot of this taking shape, also potentially having the potential to pair with some of the continuous monitoring tools that I mentioned in the previous slide. So lots of different options here for integration. But one of the things, and I'll just say as I conclude, we talked a lot about the different factors that influence interaction and how you address it, and some of the future innovations that can potentially revolutionize healthcare. But of course, if we don't address this, we know that these future innovations are actually going to widen the gap, widen the health equity gap. So it's going to, so what we want to do is effectively design technology so we can improve treatment outcomes and reduce the health and digital divide. So this is what I call inclusive digitization, okay? So there's a few questions to ask. Who is the patient? What are their needs? And what goals do they want to accomplish? Okay, these are always the preliminary questions. And then integrating that information in with some of the approaches that we talked about previously can potentially then, of course, lead to some of the enhancements or advances in healthcare outcomes that we all hope to see. So I will end there and open up the floor to Q&A or questions, Cynthia.
Great, thank you so much. We have 2 in the Q&A, and so for those people who've been posting their questions in chat, if you could move them over to the Q&A, that's where we're taking the questions from. So our first question is from somebody working in a hospital system, it sounds like. So it says, working within a hospital system, clinical staff are increasingly asking for patient ed solutions that are more digital, for example, content on TVs, apps, etc., to save time because of short staffing and high volume. How do we partner and perhaps push back on using digital technology as a time workflow solution?
Right. So I think some of the challenges with digitization, I focused a lot on the patient here and how digitization impacts the patient, but we know on the provider side, there's been also similar challenges in terms of how the healthcare provider, healthcare administrators, and other healthcare staffers engage with the technology, and that sometimes the workflow that's designed into the tool does not actually align with the actual workflow or what makes sense. So what's intuitive for the healthcare provider, and that's led to a lot of issues with productivity, a lot of performance degradation, lots of issues with satisfaction in terms of engaging with these tools. So I think this does have to be addressed as by addressing all stakeholders, right? So the patient is central. Of course, these are patient-centered approaches, but obviously a key stakeholder in this is going to be the provider, who has their own set of technology. And so that definitely has to be considered simultaneously, rather than just forcing the technology on the providers without understanding how they're actually going to use it, or why they would be using it, or what potential benefits it could provide them.
Can I ask a follow-up to that? Do you have any specific examples, either that you're testing or you think or that you know are in the works, where providers do feel like these technology options are a help to them, like, that it's more of a partnership. And so it's not just, sort of an efficiency issue, right? In terms of what the person's question was, is like, if we have less time, then we're just kind of offloading it onto the technology. But are some examples where you think providers really feel like the technology is kind of like a partnership or truly a supportive thing for them? Is there anything that you know of right now or in the works?
I would say so. So of course there's clinical, a lot of different clinical decision support tools. I would say the greatest potential, for them to kind of work more in sync with the providers' needs are in the customization of modules. For example, with EHR, which we know is notorious for being unusable for providers. I think that's probably the greatest partnership, is allowing more customization of modules where they can better engage with it, and it can supplement their activities more effectively. I think the question of offloading onto technology, there's still things that humans are still required to perform, and are still quite useful and more effective than machines, at least at this current stage of development of different technologies. And so I think that that identifying the specific places where automation can potentially help, like scheduling, for example. There's different scheduling systems that are now being piloted that are automated. That's not necessarily something that you need a human to be.
Oops, we lost you. Your screen. Are you still there?
Sorry, I think I.
Okay, well, let's hang on a second. Hopefully we can get Dr. Von Cook back.
Okay, I'm
there
here.
you are. Great. Oh, okay, no problem.
Sorry.
Yeah. Okay, no problem.
Yeah.
Good. And I was going to suggest taking it off the shared screen anyway. Great.
I'm not sure. I'm not sure what happened there, but
no problem. Did you want to finish that before we move on to the next question, or
yes,
did we get?
I think that there's there's places where things can be offloaded onto technology effectively, like for example scheduling. That's a really low-hanging fruit, I think, where there's a lot of good innovation happening where human resources are not necessarily needed in that particular case.
Great. So the next question, it says, what specific digital skills should be improved for people with low digital literacy to help them engage effectively with new tools, right? So this is like thinking ahead, you kind of talked about, some of the, from a technology perspective, what are some of those features? But if we're thinking about skill enhancement for people, right? If these tools are coming and they're going to need to engage with them, what skills might they need? And are there evidence-based trainings that are already available or that could be models for doing this skill building?
Yeah, that's a really good question. I think so there's core skills that we're talking about in terms of engaging with mobile platforms that are, or laptops or computer systems that are kind of independent of healthcare. So those are tools or skills that are needed for many different facets of life. But I do think there is a role for, for example, we've used for a very long time, like nurse educators. So why not having digital educators in the healthcare system? If this is going to be a large tenet, then why is there not someone educating the patients on basic mobile interaction with the technology, navigation? That's a huge issue that that's a huge issue that has plagued, I would say, digital interaction for quite some time. And so I think those are really some areas that could be improved upon. I think also technology access, so access to the right tools that allow you that allow you to engage with the system. Many patients don't even have the appropriate platforms that would allow them to engage with some of these systems. So I think just a need for basic software navigation skills.
Yeah.
That's really important.
And maybe this is not something that you can address, you know, with your professional hat on, but I'm hearing some potential sort of policy implications, right? So if the expectation is that there's sort of this minimum technology access that's required, maybe that's something that becomes part of insurance, right? Or becomes some way, so there's some other subsidies that are involved. So, you know, there's that equity issue. If we really want people to have access to at least some minimum set of digital tools, we're going to have to figure out how to pay for that, right?
Right, certainly, and insurance could play a role here. But also remember, these digital tools have regulatory agencies that, you know, the Office of the National Commission or the Food and Drug Administration, right? There's already rules for, you know, integrating the variability of patients into the design, although not really formalized in the way that allows enforcement. But there's, you know, that could also be baked into how the product is required to be tested for regulatory approval or to receive the appropriate accreditations or certifications. That is something right now that there's not a lot of strict regulations around in terms of teaching basic skills, right? With how to navigate and interact. Those are just things that are assumed by the manufacturer. So I think on the regulatory side, that could possibly be a potential, there could be a role. The insurers could, as they have in the past, could provide incentivizing for providers to give that service instead of manufacturers.
Well, we have three kind of related questions that all kind of still link to that. I just want to observe before I kind of talk about those three questions, is that there was a lot of money that came to states to help with digital divide issues. So for example, in Maryland, I know that the Cooperative Extension Network got $4 million to help with digital literacy. So those of you in other states might want to find out where that funding for expanding both broadband and digital literacy skills went, and start thinking about partnerships with those groups. So if you're in Maryland, start thinking about partnerships with Cooperative Extension, because they're the ones in charge of digital literacy skill building right now. So there were three related questions. One is specifically about MedStar. If MedStar has a department or a group that helps educate patients on available technology. But then there was a related question about recommendations for supporting patients who, for whatever reason, can't use digital. And then with SES being such a big barrier, how to help patients who you know, don't have this access. So those kind of are all linked to what you were talking about. If you want to say something about either MedStar specific supports or what you think of as supportive infrastructures that are still needed.
Yes. Sorry, I lost you for a quick second again.
Oh, yeah. So there's three questions that are really related to this question of support.
I heard, I heard the
great.
questions, but my video dropped for a second. Yes.
Okay.
So yes, so MedStar, the National Center for Human Factors in Healthcare does deal with some of the education-based initiatives. So specifically looking at how to better tailor resources, whether that's instructional resources for the patient, instructional resources for the provider. That is part of our role in terms of our service to MedStar, and also doing that for other healthcare systems as they approach us. We've done that for a variety of other contracts with healthcare systems, also companies. And there's also digital tools that are being developed at MedStar that are being, vetted within the organization for that purpose as well.
Great.
Um,
And you got a comment that says, great presentation, very inclusive of all the barriers that are affecting patients.
Great.
A question about your recruitment methods. What recruitment methods do you use to include diverse patient populations, such as historically underrepresented groups in the research?
Right. That's a really good question, and it's a challenge. So anytime you have a highly heterogeneous population, of course, recruitment just becomes quite challenging because no one has the resources to collect data from thousands and thousands of patients unless you have a multi-million-dollar grant. And so the question then becomes, how do you ensure that your population is stratified? And so generally what I do is identify a few key metrics that are linked to many of these factors. So in the past, and I mentioned this in the presentation, I use insurance. So that's a really low-hanging fruit, which you can get from medical records, and you can separate the patients into different insurance blocks. And generally that tends to be highly correlated with some of the other metrics. For some of the mobility-based conditions, some of those are also in medical records as well. For example, if you want to know if someone has an eye condition and you specifically want to study screen interactions, you can have that. You can also do stratification of different eye or mobility-based conditions. And generally, what I do in terms of recruitment is at different key intervals, stop, tabulate, and determine where you are, and then pivot. And in most cases, you have a lot of the low-risk patient group who gets enrolled very early, and then you have to stop enrolling that group. So I don't want any other privately insured individuals there. I can no longer recruit more of them because I don't have enough of Medicaid or non-insured patients. And that's very often what has to happen because, of course, low-risk patients who don't have a lot of functional limitations like mobility and have high health literacy, high tech competence tend to be recruited at a faster rate. So you have to calibrate and stop at different periods of your recruitment to account for that, to ensure that at the end, after recruiting, let's say 100 patients, you don't find out like, oh, I have the healthiest of the healthy patients and very high health literacy patients. That's definitely not something that you want.
So I just want to say our speaker who just joined us, we're not done yet. So we'll transition to our next session in a minute. So there was a question about privacy and confidentiality of patient information. At what point do we seek consent in the process of building digital apps?
Right. So, so depending on what perspective you're coming from, so if you're doing research and you're engaging with a patient at any level, of course, there has to be consent for using their information. And whether it's surveys, et cetera, if that's from the research perspective. Now, if it's outside the research perspective, if it's being used for consumer-based services, it doesn't necessarily have to go through an institutional review board, et cetera, but you do want to observe some type of informed consent for those purposes. And so I do think that that does have to be considered at all levels. I think anytime you engage with the patient and you're collecting their information, you do want to observe informed consent procedures. Now, if you're using information from their medical records and using it internally for interventions and treatment-based strategy, of course, the patient has already consented to give you their information. So that's a slightly different scenario for informed consent. So I think it really depends on who you are in the healthcare system or in the digital design of digital tools, what stakeholder you are, at what point you access or request that informed consent.
Great. Thank you so much. And then just one comment about vendors potentially being partners in helping on the skill building for patients. So thank you so much. And a lot of people saying thank you for this presentation, that it was very helpful and very nuanced in considering all the issues. So thank you so much for taking time out. letting us learn a little bit about this really great center that you are now directing. So thank you for your time and all this great information.
Okay, and thanks for inviting me. Thanks
All right,
everyone
take
for
care.
attending.
All right,
Okay,
bye-bye.